discontinued. There was no infection found on the patient, and when insufficient, the medications may lead to exacerbations of symptoms. In terms of the relative safety of the chosen medications, we identified a possible problem in terms of toxicity for digoxin and warfarin due to their narrow therapeutic index. And has the therapy been tailored to this individual patient? We did not think so in terms of the warfarin, because we read that from our references that warfarin is usually given for 2 days, and then the patient's INR was measured, and then based on that the measurement, the dosing will be adjusted. Since the patient was not administered this drug while being admitted, so we considered it as not being tailored, the 2.5 milligrams 1 tab OD. And also ceftriaxone and clindamycin were given without a clear indication, so we can also consider this treatment as not being tailored for the patient. In terms of the drug regimen, there were prescribed drugs with prescribed dose and dosing frequency that we did not find appropriate for the patient. For the enoxaparin, there's a possible transcription or prescription error, since enoxaparin is not available as 0.6 IU, but either 0.6 cc or ml, 60 milligrams, or 6,000 IU, prefilled syringe. And then for the prescribed dose, atorvastatin could be lowered to 40 milligrams OD. And the dosing, also for the dosing frequency of lactulose, it could be lowered from BID to OD. For the under drug regimen, is the PRN use appropriate? We think more information is needed, since although high glucose reading was made, there's only one measurement. So, and since we did not see the CBG monitoring, it's possible the patient may have CBG levels within normal range. So the PRN order is not a problem. In terms of the route, dosage form, and mode of administration, we saw that the still in terms of the PRN meds, that one vial D50-50 was not prescribed with the route of administration. The same for in the regular insulin sliding scale. For Humulin R6 units, no route of administration was indicated by the prescriber. We did not see any problems under the therapeutic duplication and the questions for drug allergy or intolerance of the patient. In terms of adverse drug events, we considered the sudden increase in cholesterol level as a medical problem that was drug induced, probably due to the high dose of atorvastatin. In terms of drug interactions, we found several. For example, warfarin and enoxaparin may result in increased risk of bleeding. For spironolactone and valsartan, the patient may experience or may have an increased risk of hyperkalemia, as well as increased risk of serum creatinine elevation. For spironolactone and lactulose interaction, it might cause hypokalemia. And spironolactone against enoxaparin, as well as enoxaparin and sacubitril valsartan, both drug interactions may cause hyperkalemia. For digoxin and carvedilol might cause increased digoxin levels by enhancing the absorption of digoxin, while a combination of interaction between digoxin and atorvastatin may also increase levels of plasma digoxin. For spironolactone and carvedilol, the patient may experience hyperglycemia and hypertriglyceridemia. For carvedilol and sacubitril valsartan, pharmacodynamic synergism or more experience hypotension, because of these two drugs are for maintenance or control of blood pressure. And lastly, atorvastatin and sacubitril valsartan may increase this interaction between them. Sacubitril valsartan might increase the toxicity of atorvastatin and cause rhabdomyolysis. And we found one possible drug laboratory test interaction. Yes. So spironolactone may result in false increases in digoxin levels. We did not find any medications indicated to the patient. One possible drug nutrient interaction is warfarin and vitamin K rich foods, since uh, foods rich in vitamin K may lessen the activity of warfarin. In terms of social or recreational drug use, since he's a smoker, smoking may decrease the effectiveness of warfarin. And since he is an alcoholic beverage drinker, this in this uh, in this case, the levels of carvedilol will be increased, might be increased. And we did not see any symptoms that might be caused by withdrawal from his methamphetamine use. In terms of failure to receive therapy, um, has the patient failed to receive a drug due to a system error or non-compliance? Yes. Non-compliance due to in his medications, and due to several missed doses of his medications upon admission. And some factors we considered that may hinder his the therapeutic efficacy of its drugs is the cost of medications and still the patient's non-adherence. Under financial impact, are the chosen medications cost effective? We considered that enoxaparin and sacubitril valsartan might be too expensive for our patient. And yes, it might represent a financial hardship, but more information is needed, since during the history taking of the patient, no employment status was mentioned, or source, oh yes, as source of employment or source of livelihood. And uh, the cost might be related to the medications, non-adherence of the medications. In terms of the knowledge of the patient of his drug therapy, um, we think more information is needed for a determination, because also the literacy level or the education attainment of the patient was not determined. So we don't know if in terms of his understanding of his medications, we can base it on his literacy level. And but we think the patient would benefit from a written and verbal education. So with the verbal and written education, the patient will the patient's compliance to his drug medicines will be enhanced. Thank you.
Okay, thank you. Okay, Sir Bas, pa-share lang muna ng slide. Thank you.
Yes po, ma'am. Ma'am Jean, confirm ko lang po,
Yes.
ang group 6 na po is hanggang ditaw at ditaw lang po ba? Or hanggang DTPL po?
Oo, hanggang DTPL sana. Pero we can parang have a brief summary of what you have presented. Kaya share na lang muna. Thank you. Sige, so while Sir Bas is sharing again his PowerPoint, okay, can we just parang level off lang ng profile ng patient? Okay, what are again the current or the working impression kay patient? Or again, what are the set of clinical conditions that our patient has? Anyone, based on the patient profile, anong pinakasakit ni patient? Pwedeng sa chat, pwedeng basahin sa sa case? Okay, I think what's the most evident na sakit ni patient na meron siya? May stroke ba si patient?
Yes po.
Okay, what type of strokes ang meron kay patient?
Base po ma'am sa PWI ang cardioembolic stroke po.
Okay, thank you, Sir Bas. That's correct. No, cardioembolic stroke. Okay, so review lang natin yung characteristic ng stroke. There are two general types of stroke. So i-trace down lang natin kung nasaan si cardioembolic. So there are two types of stroke. One is ischemic stroke and then the other one is hemorrhagic stroke. Okay? So sa ngayon, pag yun muna yung titingnan natin, ischemic stroke and hemorrhagic stroke, alin yung meron kay patient? Based doon sa data na nasa natin, case. Meron bang ischemia si patient? Nagkaroon ba siya ng meron bang occlusion? Meron bang infarct? Yes, no? Meron siya. Okay, so therefore, between the two general types of stroke, the patient had a ischemic stroke. So ischemic stroke is more common, much more common than hemorrhagic stroke. About 88% of stroke cases is of ischemic type. Okay, so ito yung may atherosclerosis or nagkaroon siya ng blood clot mismo sa brain or yung atherosclerosis niya pwedeng galing sa heart. Okay, pwedeng galing sa other parts ng body na nag-occlude no, sa kanyang cerebral artery. So that's the ischemic stroke. And then the remaining 12% is of hemorrhagic stroke. No, ang hemorrhagic naman from the term, then there is an abnormal bleeding in any of the cerebral arteries. Okay, and then, so since na-narrow down natin na merong ischemic stroke si patient, and then cardioembolic stroke is the most common type of ischemic stroke. Okay, cardioembolic is the most common type of ischemic stroke. Alright, and then, ano pang meron kay patient bukod sa stroke? Before tayo mag-summarize ng onte doon sa report ni na Sir Bas, meron ba siyang heart failure? Yes, very correct, Ma'am Maren. Okay, may heart failure siya because or due to ischemic heart disease. Okay, so parang nag-o-overlap yung disease niya, no? Nagkaroon siya ng ischemic heart disease, meaning, okay, pag ischemia is hypoxia, no? Low oxygen supply. Okay, so because of low oxygen supply sa cardio or sa heart tissues, nagkaroon siya ngayon ng heart failure. And then, meron din siyang hypertension no, na nabanggit ni Sir Bas kanina. So long-standing hypertension can lead to heart failure. Alright? Tapos, ngayon, yung stroke ay clear na sa atin no, na ischemic type of stroke siya. So yung mga naka-abbreviate, LMCA, PCA, mga ano lang ito, specific names of cerebral arteries. Okay, ano nga ulit yung LMCA, Sir Bas? Kanina? Ano yung meaning niya? Or anyone?
Hello, ma'am.
Sir, Ma'am Grace.
Ma'am, ano po, yung LMCA is left main, sorry ma'am, left
Sige
main
lang.
coronary artery cardioembolic.
Okay, coronary artery pala ito, no? Ulit. So, ulit ma'am, left main.
Left main coronary artery
Okay.
cardioembolic po.
Alright, ma'am. Thank you. PCAI. Ma'am Grace, kung meron ka pa. Yung
Posterior
mga,
cerebral artery stroke po.
okay, alright. Thank you, Ma'am Grace. So,
Apa.
yung terms natin ay general naman, ano, or ang ibig ko lang sabihin, may clue tayo, no? Pag coronary, meaning artery siya ng heart. Pag cerebral, artery siya ng, okay, ng brain, of course. Okay. So then, punta tayo ngayon sa chief complaint niya. Dinala siya sa hospital primarily because of stroke symptoms. Okay, may slurred speech, right-sided weakness, and then, okay, so that's the main cause of bringing the patient to the hospital. Alright, kaya, ayan, kaya, ang present working impression sa kanya is cardioembolic stroke and acute cardiovascular disease. So, yung acute cardiovascular disease, very general, very umbrella term, okay, na nagfo-fall down sa kanya or categorized under sa kanya ang stroke. Okay, so going back now to the report, okay, pili tayo ng isang problem. Siguro yung first, start tayo sa first, and then let's ask other groups if they had identified the same problem. Ma'am Erica, ilang minutes nga tayo per group para matapos tayo ng 12?
Kinalculate ko, ma'am, nasa 20 to 25 minutes po.
Okay. So, si group 6, dapat matapos siya ng anong time? Pa-chat na lang, Erica, ha? Thank you.
Okay, ma'am. Sige po.
Alright. Sige. Okay. So, ang first drug therapy problem ay, are there drugs without medical indication? Okay. So, group 6 had identified 2. Ceftriaxone, clindamycin have no clear indication. Okay, may I ask group 5 to 1, pareho ba kayo ng nailagay? So we can compare. Okay, group 1, yes. Okay, group 2. Kasi pag may naiiba, then that's good to discuss, no? Yes, group 2 also said yes, same therapy problem, no clear indication. Group 3, yes, then group 4. Sige. So let's wait na lang. On group 5, you can chat or send. Okay, sige. So since majority sa ngayon, no, may 4 groups tayo. We didn't include it, okay, because it was discontinued after the results of gram staining was released. Okay. Anong date yun din-discontinue? Tingnan natin, Sir Dario. Tingin din ako sa patient case. Okay. Anong date din-discontinue? In-admit si patient November 7. Tapos, din-discontinue siya ng okay, November 11, hindi na siya pinainom. Okay. December 10, hindi na din siya pinainom ng ceftriaxone. No? But then, parang nag-3 days siya, no? Nung dalawang antibiotics na yan. Okay. So, ngayon, at the start, walang clear indication. Ano, para saan? Okay? Kasi, I agree doon sa emphasis kanina ni Sir Bas na if it is a hospital-required type of pneumonia, pwede kasing ibigay si ceftriaxone, clindamycin for lung infection. But then, ang hospital-acquired pneumonia, di ba, must be diagnosed when the patient was admitted within 48 hours. No, dapat nakastay siya sa hospital ng 48 hours. Yun yung time observation. Observation time. Naka 2 days siya, full 48 hours na nasa hospital. And then after that 48 hours, nag-develop siya ng pneumonia, then that is HAP, na hospital acquired. So ang Parang ang assumption ng group 6 ay baka community-acquired pneumonia. Okay. Pero ano nga ulit yung reason niya group 6 kung bakit ay hindi din siya pneumonia? Hindi din siya CAP? Ano nga yung reason niya kanina kung bakit dinismiss niya din yung CAP? Kaya niya nilagay dito na wala talaga siyang no, clear indication ang ceftriaxone and clindamycin.
Hello po, Ma'am Jean.
Yes.
Sa amin po, diniscontinue siya kasi after 2 days, negative po siya sa gram stain.
Okay.
Pagkatapos po, yung sabi po sa chest x-ray na is suspected lang naman po yung infiltrates sa right lang.
Okay.
Right.
Okay, correct. So ngayon, pwede na nating isipin or i-review, no? Ano nga ba ulit yung diagnostic procedure for CAP? Ginawa ba sa patient? No? Yung sputum ba siya? Yung pinaka-basic na test. Actually, wala din yung sputum. Wait lang. Bumabalik ako na sa patient case. Okay, sputum. Ano nga ang result? Kung sputum, no growth din. Okay, yung chest x-ray nga sana na dapat may lateral, posterior, yung pinaka-specific na position na to get a parang a more accurate diagnosis of pneumonia, wala din. Kaya yung suspected it's a vague, no? Vague basis pa to tell. Alright. Sige. So ngayon, majority of the groups have identified that no, ceftriaxone and clindamycin have no clear indication even at the start. Okay? Sige. So since hindi natin maiisa-isa lahat ng drug therapy problem, okay, recorded naman to, makikita naman nila ang presentation ng anyway, our goal is for everyone to present, no? Kaya I think as we go on, we can discuss other drug therapy problems, especially in PCP, no? Pharmacist care plan. Alright. So group 6 is until 9:55. Okay. Sige. You have questions for now, for as of this time, for group 6? Wala naman, na medyo sobrang lang tayo, no? Limited yung time. Sige. Anyway, so let's start with group 5. Okay, so group 5 can present their DTPL and maybe yung start first entry sa PCP. Okay, group 5, you can now share your DTPL output. Thank you.
Morning po. Kita po ba yung slides?
Yes, kita na namin. Thank you.
Kita po, sir.
Okay. For the DTPL po, good morning po pala again. We are group 5. For the DTPL, I will call my group mate, Miss Mama Bell, to discuss the following DTPL. Thank you. Okay, parang may technical issue lang po si Mama Bell. So, to start na lang po, ito po yung the following group 5 has listed the drug therapy problem. So, one is we found out that one problem is an unidentified medication prior to admission. So, our group intervention suggested that thorough medication history taking of the patient with regards, if ever possible po, sa caregiver and family member. We also found out that one problem to be managed should be the underdose of enoxaparin, and we suggest to increase the dose of enoxaparin to 6,000 IU, subcutaneous Q at 12. Also, another problem that we have discussed is the omission of dose of Humulin R 4 units, stated. And as an intervention, we should strictly monitor CBG level of the patient. Other problems that are being discussed are the following: the missed dose of the drug regarding clindamycin, 600 mg, the enoxaparin missed dose, the atorvastatin missed dose of atorvastatin 80 milligram tab every bedtime, which has not been given on the following dates as stated on 9, 10, and 13. Also, the digoxin missed dose that are not given also on the following dates. The carbidopa missed dose which are not given on the following dates also as stated. The lactulose 30 ml twice a day, which would been which has also been stated on the result of the chart. Warfarin 2.5 milligram tab, which is also not given on the following days 12 and 13. Sacubitril and valsartan 50 milligram tab, which was given on 11-13. Spironolactone 25 milligram, which was given on 11-12. And chlorhexidine gargle, which has been given on 11-9, 11-11, 11-12, and 11-13. So as intervention suggested by our group is to monitor the accuracy of timeliness of administration and documentation, and to validate with the assigned nurse why meds are not given. So also one problem is the duplication of therapy for pneumonia, which antibiotics which were given were clindamycin and ceftriaxone, and we suggest to continue ceftriaxone for 4 more days to complete the 7 days, then repeat 6 or just X-ray. So also one problem is the unavailable resort of the PTINR, which is prior starting warfarin. It was not stated on the case report. So we should, as our suggestion would be, wait for the PT or INR result prior to starting of warfarin. So ito po yung following drug interaction which we found out as a problem also. The digoxin and versus the atorvastatin, that atorvastatin may increase the serum concentration of digoxin. As our suggestion, we should monitor closely for signs and symptoms of digoxin toxicity when adding atorvastatin, and stated on the slide. So also another problem we found out is the interaction of digoxin and carvedilol, which digoxin may enhance the bradycardiac effect of carvedilol, and carvedilol may increase the serum concentration of digoxin. So as suggestion, we should monitor for bradycardia or heart block, as well as potential increase in digoxin concentration. Another drug interaction is carvedilol versus sacubitril valsartan, which are both blood pressure lowering agents and may enhance the hypotensive effect of hypotension associated agents. So as suggested, also as we found out as the reference, Lexapro, although the concomitant use of the 2 or more drugs that may lower blood pressure, either as a therapeutic intention or as an adverse effect, it is often clinically appropriate use of such combinations often substantially increase the risk of hypotension. We should monitor the patients closely for additive hypotensive effects of 2 or more of these agents are combined, and possible increase of blood pressure. Monitoring is advised and dose adjustments may be required. So another drug interaction that we found out is the ceftriaxone versus warfarin. which cephalosporins may enhance the anticoagulant effect of vitamin K, vitamin K antagonist. So as suggestion, we should monitor for elevated INR and bleeding if a vitamin K antagonist is used in combination with cephalosporins. Cephalosporins that have an NMTT or side chain in their chemical structure may pose a greater risk of interaction. Another problem also we found out is the digoxin versus spironolactone, which spironolactone may increase the serum concentration of digoxin, and spironolactone may also interfere with the assays used to determine the digoxin concentrations, falsely increasing or decreasing digoxin concentrations. So as our group suggests that we should monitor patients closely for signs or symptoms of digoxin toxicity when using digoxin spironolactone in combination. Included in the list of drug interactions is also enoxaparin versus warfarin. This may cause dependencies on laboratory or diagnostic results, which says that if combined use of this agent should be avoided once INR established in the desired therapeutic range. So the group suggests that when transitioning to warfarin from therapeutic anticoagulant with a parenteral anticoagulant such as heparin, low molecular weight, heparin the parenteral agent and warfarin are generally overlap for at least 5 days and for at least 24 hours or 2 consecutive days after INR has reached the therapeutic range. So ito po, just to go down from the therapeutic enoxaparin, there is an overlap therapeutic dose of enoxaparin with warfarin for at least 5 days and until INR is in therapeutic range for 24 hours. Also, list of drug interactions such as enoxaparin versus sagopitril valsartan. Heparins may enhance the hyperkalemic effect of angiotensin II receptor blockers, which is that we should monitor the serum potassium concentrations closely in patients receiving angiotensin II antagonists in combination with low molecular weight heparins. Another set of drug interactions are enoxaparin versus spironolactones. These are heparins, may enhance the hyperkalemic effect of potassium-sparing diuretics, which is spironolactone. So we should monitor serum potassium concentrations closely in patients receiving potassium-sparing diuretics in combination with low molecular weight heparins. Sacubitril versus valsartan versus spironolactone. Routine combined use of an angiotensin converting enzyme inhibitor, an angiotensin II blocker, and aldosterone antagonist such as spironolactone is not recommended for patients with heart failure. As stated on the patient's case, that we are established that there is a heart failure with reduced ejection fraction. So we suggest that we should monitor and increase the risk, monitor for increased risk of hyperkalemia during concomitant use of angiotensin II antagonist. So there is one problem should also be managed is the drug nutrient interaction of digoxin, which is the correct electrolyte. We should monitor the correct electrolyte disturbances, especially hypokalemia or hypomagnesemia, prior to use antoro therapy. Warfarin also it has also a drug nutrient interaction, which is warfarin diet. Because the patient is in warfarin, so warfarin diet is advised. So warfarin diet includes the avoid leafy vegetable or potassium rich food. Spironolactones, serum potassium and renal function should be checked and avoid potassium rich food. So yun lang po as indicated on drug therapy problem list of group 5. Thank you.
Okay, thank you, Sir Eric. It was a complete discussion, especially on drug-drug interactions. Okay, so let's have a parang recap lang of the different indications of the drugs given to the patient before tayo pumunta sa specific na drug-drug interaction. Okay, Sir Eric, papa-flash, share mo ba yung patient case? I-run down lang natin yung drugs prescribed to him.
Wait po
Thank you. Sige, habang pinaprepare ni Sir Eric, yun, i-recall lang natin yung different therapeutic classes and then the indications of each of the drugs given. Sa page 6 at yun, yung compliance chart. Yan. Sige, baba pa Sir Eric. Thank you. Ayan. So, yan lang yung i-discuss natin. From clindamycin to humulin, ano lang, parang fast talk lang muna tayo. Okay, clindamycin, recall, what's the therapeutic class and indication? Anyone? Alam natin na antibiotic sila eh. No? Pero what's the specific therapeutic class of this? Pwedeng chat,
Ma'am,
pwedeng... Opo. So,
Lincosamides po, ma'am.
okay, very good. Lincomycin or lincosamide. Okay, ang ginagawa nila ulit ay 50S no inhibitor, 50S bacterial inhibitor, kaya antibiotic. Okay, for infections, no, varied from soft tissue infections such as ear to lungs, etc. Ceftriaxone, therapeutic class. Anyone? Correct? Correct, Ma'am Mabel. No, it is a cephalosporin. Can we still recall kung anong generation ng ceftriaxone? First gen, second, third? Okay, thank
Third po,
you.
ma'am.
All right, very good. That's correct. Third. Okay, correct, Ma'am Shirley, Ma'am Hershey, Ma'am Glenna. Ay, tama, Ma'am Glenna. Okay, so third generation. Ceftriaxone. So, kaya, antibiotic. Okay, enoxaparin. Okay. Enoxaparin, kanina, nasabi ni Sir Eric, it is a low molecular weight heparin. Okay, therefore, what's the therapeutic class of heparin? Antithrombotic, anticoagulant, antiplatelet, etc. Okay, it is an anticoagulant. Okay. Next, very good. Naalala pa, atorvastatin. Atorvastatin. So, heparin and warfarin, no? Ay, hindi, mamaya na nga lang. Andun pala sa baba si warfarin. Okay. Okay, so atorvastatin, ano nga ang pangalan ulit ng statins? Okay, correct, Ma'am Maren, no? AHMG-CoA reductase inhibitor. I think memorize pa naman ang ibig sabihin no, ng HMG-CoA. Alright, sila ang best na the most effective agent no, in lowering LDL. Okay, digoxin. Digoxin therapeutic class. Okay, it's a glycoside. Correct, Ma'am Grace. A cardiac glycoside. It is also an anti-arrhythmic agent, though ang kanyang side effect no pag nagkaroon ng digoxin toxicity ay arrhythmia din no pero pwede din siyang anti-arrhythmic agent. Okay, very good ang recall. Carvedilol all beta blocker. Okay, next, lactulose. No, lactulose, sabi kanina, it is for constipation, then therefore this is Laxative. Very good, Ma'am Sela, Ma'am Aryan. A specific type of laxative. Osmotic. Very good, Ma'am Mobel. Okay. But then, I'll just add, no, si lactulose, aside from being a laxative, nasabi natin pag may stroke, may hypertension, we avoid no, the difficulty in straining. Okay? Okay. Sa isang banda, no, si lactulose ay antioxidante, which can also prevent or decrease the risk of reoccurrence of stroke. So meron din siyang ganong use, no, as an antioxidant. Okay, hindi lang as a laxative agent. Okay, warfarin. Warfarin is same family of heparin, no? It is also an anticoagulant. Correct, Ma'am Bobel? Okay, pero magkaiba, no? Distinct na ang mechanism of action ng heparin and warfarin. Okay, sa Cubitril and valsartan. So this is a fixed dose combination. Okay, therapeutic class muna ni sa Cubitril. Ano siya? Okay, correct, Ma'am Glenna. It is neprilysin inhibitor. Okay, neprilysin inhibitor. Okay, main indication of this is heart failure. Yung combination is specifically, it's not for hypertension, it is for heart failure. So it's a new class of drug, no, ang neprilysin inhibitor. Okay, next, valsartan. Valsartan is an ARB. Okay, so angiotensin receptor blocker. Thank you. Correct, Ma'am Glenda. No, it is always an alternative to ACE inhibitors, ang mga ARBs. Spironolactone, nasabi kanina, no, it is a potassium-sparing diuretic. Okay, so since the patient may heart failure, okay, what do you think is the diuretic of choice pag may heart failure? Kasi we have so many types of diuretics. We have the loop, we have the thiazides, we have the osmotic, etc. Thank you. Kasi kanina, no, pag pinansin natin, I think no, most of the groups, marami ang drug-drug interaction ni spironolactone, lalo na in controlling ng potassium levels. Si potassium levels pa naman ay sensitive si digoxin. Okay? So for a heart failure patient with heart failure, okay, the group of choice, the diuretic of choice is the loop diuretic. Okay. Very good. Correct, Ma'am Glenna. Correct, Ma'am Aryan, Ma'am Hershey, Sir Daryl, Ma'am Zella, Ma'am Sherney. Okay. Si loop diuretics. Okay. Next. Chlorhexidine. Okay. Hygiene. Oral hygiene. And then D50-50. Okay. Large volume parenteral, Humulin R, okay, not to decrease that glucose levels. Okay, so na-run down na natin. Then let's go to an example of a drug-drug interaction. Kahit isa lang muna, Sir Eric. Thank you. Pa-share screen ulit, Sir Eric, ng list mo ng drug-drug interactions. Thank you. Yeah, okay. List of those. Okay. I think nasa babae yan. Ayan. Okay. Sige. So there are so many drugs na tinitake ni patient na nag-a-affect ng serum concentration. Alright. Atorvastatin increases the serum concentration of digoxin. Eh, alam natin si digoxin, low therapeutic index, dapat may therapeutic drug monitoring siya, no? Kasi ayaw natin ng digoxin toxicity. Okay, so ngayon, may drugs siyang iniinom na, okay, magpapataas pa pala ng serum levels ng digoxin, which is atorvastatin and, meron pa bang iba? Carvedilol. No? Carvedilol also increases the serum concentration of digoxin. Okay, other groups na identify nyo ba to na drug-drug interaction sa inyong DTPL? Drugs increasing serum concentration of digoxin that may lead to toxicity. Okay, okay, very good. So ngayon, si digoxin toxicity, kung ifo-focus natin siya, aside from these drugs that would increase the serum concentration, meron pang isang kabila, no? Meron ding drugs na magli-lead to meron ding set of drugs na iniinom si patient na magli-lead din to digoxin toxicity by decreasing potassium levels. Diba? Kasi pag ni-recall natin, digoxin is potassium sensitive. When the patient is hypokalemic, then the patient is of high risk for digoxin toxic effects which is arrhythmia. Kaya inaantabayanan natin o binabantayan ang potassium levels ni patient. Kasi pag bumaba, increase rin siya sa toxic effects ni digoxin. Okay? Kaya medyo, what I mean is, anong term doon, no? Napaka-sensitive no, na drug ni digoxin. No, sa kabila, may sa kabila, what I mean is, both set of drugs would lead to digoxin toxicity via different mechanism. Okay? So, wrap up lang natin ng onte. Unang part, atorvastatin, carvedilol would increase serum concentration of digoxin. That will lead to toxicity. Okay? Sa kabilang banda, ano tong mga drugs na to na magpapababa ng potassium na magli-lead din ulit sa toxicity. May nag-chat na po ba? Ano iniinom ni patient? Meron pa magpapababa ng potassium? O wala? Other groups you can identify. Okay, lactulose. Lactulose can decrease potassium levels. Okay. Meron pa ba? Spironolactone is potassium sparing. Okay? So, i-reserve niya. Isi-save niya ang potassium from being secreted. Okay, so therefore, sa set of medication natin ay si lactulose ang pwedeng magpababa. Okay. Okay. Ayan. So, tandaan ulit that hypokalemia would lead to digoxin toxicity, okay, which is arrhythmia. Okay, next tayo. Isa pa nga tayong drug-drug interaction. Okay, digoxin and spironolactone. Okay, spironolactone may increase serum concentration also. Okay, so Okay. Back. Enoxaparin versus warfarin. Okay. So this interaction is significant. It's a major drug-drug interaction because ano ang kanilang combined effect? Ano ang combined effect ni enoxaparin? Enoxaparin, heparin, anticoagulant. Warfarin, anticoagulant. That will lead to, okay, significant bleeding. Okay. Okay, so I think common to na ma-identify ng ibang groups. Alright, so ano ang intervention ninyo, Sir Eric dito? Since sa enoxaparin and warfarin ay pareho, meron bang dapat gawin? Or magkaiba naman ng time of administration kaya okay lang na walang gawin?
So ito po sa last yung from therapeutic and enoxaparin doses. We stated here that overlap therapeutic dose of enoxaparin with warfarin for at least 5 days and until INR is in therapeutic range for 24 hours. So parang we have to check on the INR value po before we proceed to overlapping of the therapeutic dose po.
Okay. Sabi, I'll repeat that lang. Ang overlap therapeutic dose of enoxaparin with warfarin for at least 5 days. And then after that, okay, monitoring is through INR. That's correct. No, si warfarin ay INR is in therapeutic range for 24 hours. Pag nasa therapeutic range, would this mean that may aalisin kayong isa or ano yung suggestion ng group dito? Or tuloy lang ba yung warfarin kasi ini-stop naman yung enoxaparin? Kasi IV si enoxaparin, tapos si warfarin ay oral. Okay. Other groups? Ano yung idea din niya dito sa enoxaparin and warfarin use? Any group pwedeng mag-contribute? Okay. Okay, stop na lahat. Okay, discontinue warfarin. Okay, kasi si enoxaparin ay, wait lang, tingin ako ulit. Si enoxaparin, tinigil na siya. 3 days lang IV, okay? Tapos si warfarin, pag tinignan natin, after siya binigyan ng enoxaparin, okay, saka binigay yung warfarin, 1 tablet once a day. Okay, so ngayon, ang suggestion ay nasa chat, okay? I-stop na lahat and then switch to aspirin combined with clopidogrel. Okay, for maintenance, ito Ma'am Grace. Ang ano ba dito? Ang suggestion?
Opo, sana ma'am. Hello ma'am. Opo,
Hi, Ma'am
sana.
Grace.
Hi ma'am.
Okay.
Tapos pwede din
Maintenance.
naman, ma'am,
Sige.
habang admitted pa siya, parang isi-shift na agad ng mga doktor.
Okay.
Kasi parang may time frame lang po sila na magkasabay. Yung bridging ba ma'am? Bridging.
Oo. Correct.
Opo.
Yun. Okay. Tapos, may ano kayo? Desired or anong tawag doon? Dose kay patient ng aspirin clopidogrel as maintenance therapy. Anyway, pwede naman nating tingnan yun no, sa reference natin. Aspirin, clopidogrel. Clopidogrel 75 milligrams, aspirin 25 milligrams. Okay, so, ayun. ang main goal ng combination na ito is for secondary stroke, secondary prevention of stroke, yung maulit-ulit siyang ma-stroke. Okay, thank you, Ma'am Grace. Ma'am Zella, bakit i-discontinue din yung warfarin? Ano yung reason?
Same pharmacologic effect po kasi, yung enoxaparin, ma'am, no? Kasi ang enoxaparin, ma'am, is prevention lang siya ng DVT for patients na merong MI, katulad kay patient. Tapos si enoxaparin is usually given lang po siya 3 to 5 days until hemodynamically stable po siya.
Correct. Ayan. Sige. Okay. After nun, ay, 35 na pala. Sige. Okay, so thank you, Group 5. We have discussed, I think, 3 drug-drug interactions plus the all the indications of the drugs given to the patient. Okay, so let's go to Group 4. I think we can start now with PCP. Okay. Titingnan natin dito kung ano prioritize ng Group 4 na healthcare needs. Okay. Sige. You
Hello
may
po,
start,
good
ma'am.
morning. Good morning po, we are Group 4. We are going to talk about the PCP or the pharmacist care plan of our patient RDT. So our highest priority is the management of our heart failure. So our pharmacotherapeutic goal is to maintain the normal heart rate, and our recommendations would be, hello, yes ma'am. Hello? Can you hear me? Hello? Hello? Okay.
Willing naman sa
Okay.
part namin.
I can hear you po, Ma'am Shirley. Baka nag-hang po si Ma'am Jane.
Okay po. Okay, so continue lang ako, Ma'am Erica.
Ayan, nawala siya. Sige po, Ma'am Shirley. Continue na lang.
Okay. So going back, our recommendation
Ito na
or
ako ulit.
intervention.
Thank you.
Yes, ma'am. So our recommendations to maintain the normal heart rate would be to promote medication adherence, to check the pulse regularly, and to recommend light exercise and lifestyle modification for the patient. Then we also suggest to check the heart rate through ECG annually, and once a year would be okay, since medyo expensive naman din si ECG. And then the monitoring parameters of the pulse and the ECG would be the normal pulse rate and the normal heart rate, which is equal to 60 to 100 beats per minute, and our desired earth point would be at least 80 beats per minute. And then the checking of the pulse rate or checking of the pulse rate would be at least 3 times a day. Then our next recommendation for our goal to maintain the normal heart rate would be to suggest to monitor electrolyte levels, since yun nga si digoxin is very sensitive to the potassium levels of the patient. So our comprehensive metabolic panel to be done once a month, and then our monitoring parameters would be the sodium, potassium, and calcium levels of the patient. Then lastly, we suggest to discontinue either warfarin or enoxaparin because of the therapeutic duplication and the risk for hemorrhage. And we also suggest to discontinue digoxin because it's contraindicated for heart attack. Our next goal would be, or the next priority would be the management of hypertensive heart disease. And our therapeutic goal would be to maintain the normal BP levels of the patient. And to do that, we need to promote medication adherence and to check the blood pressure at least once a day, combined with the lifestyle modifications. So the light exercise and the diet modifications. So our monitoring parameters would be BP levels equal or not more than 130 mmHg over 90. So at least once a day. And then our next priority would be the management of drug-induced hyperkalemia. So our therapeutic goal is to maintain normal potassium levels. And to do that, we need to include the serum potassium level in the lab test. So we also suggest to shift potassium sparing diuretics to loop diuretics, uh which is the drug of choice for heart failure. So our potassium levels should be 3.5 to 5.1 millimoles per liter, and it should be checked, or yes, it should be checked at least once a month. Our next priority would be the blood glucose of the patient. So we need to maintain the normal blood glucose level, and to do that, we have to check for the blood glucose levels, or yes, before every meal and before bedtime through a glucometer. So random blood glucose levels would be our main parameter, since fasting blood sugar levels would require fasting. So our normal or our target blood glucose level would be 130 milligrams per deciliter and should be checked 4 times a day before every meal and before bedtime. And also, we recommend diet and alcohol restriction. We need to avoid sweets and sugary drinks, low carb and low sugar diet, and light exercise. And then our next goal would be to minimize drug induced adverse drug reactions. So we suggest to discontinue spironolactone due to numerous drug interactions with the other medicines that has been prescribed by the patient for the patient, and it could also cause hyperkalemia. And we also suggest to change the timing of carvedilol and the sacubitril plus valsartan, so that um, no interactions and no uh, therapeutic duplications would be experienced. And then we also recommend to again monitor the potassium levels at least once a month. And then our next suggestion or recommendation would be to suggest to discontinue atorvastatin due to no clear indication, and to check for cholesterol levels annually through the lipid panel, because as seen in the lab test of the patient, the cholesterol levels of the patient and the triglycerides were within normal range. And we suggest to get the lipid panel test at least once a year. Next. And lastly, our next goal would be for preventive therapy for B6 and B12 deficiency. And our therapeutic goal is to normalize the levels of MCV and MCH and the ALT and SGPT. So to do this, we suggest to add vitamin B complex to the drug therapy of the patient and to monitor its levels through CBC quarterly. So these are the normal levels that we target for the patient. And we suggest the CBC and the monitoring of these levels to be done 4 times a year. That's it, ma'am. Thank you.
Okay, thank you, Group 4. Sige, paano ako ng onte, pa-zoom out para kasya lang sila sa isa. Ayan, 100, kahit 100 siguro. Okay, so ano ang pinaka-prioritize nyo na healthcare need ni patient?
The management of heart failure po.
Yung number 1, healthcare. Okay, management of heart failure. Okay, so may I ask the group, bakit ito yung identify niyo as the most priority? Kasi actually wala namang mali, no, in terms of accomplishing a PCP. No, as long as you can justify kung ano yung ano yung unang healthcare need na nilagay ninyo, that it's okay. Okay, si patient may heart failure, siya, no? Diagnosed siya with heart failure because of yung second na healthcare need nyo, which is hypertensive, no, heart disease. Nagkaroon siya ng chronic hypertension, nag-lead to heart failure. From heart failure, nagkaroon na siya ng stroke. Saan-
We suggest to manage the heart failure first priority because if we manage it first, everything else comes to place. And yung sa past medical history po ni patient, known na po siya na meron siyang heart failure, and then parang na how do you call this, parang gumrabe lang siya because of his non-compliance.
Okay.
To his medicines.
Kailan nga siya
Tapos
na-diagnose?
2017 po, known with heart failure
Correct yun.
and hypertensive heart disease.
Heart failure niya, 17.
Yes po.
Alright. Parang ako yung naglalag. Siguro, yung internet ko siguro. Mag-off lang ako ng camera. Ayan. So, 2017, correct, na-diagnose siya with heart failure. Okay, andito na ako ulit. Sorry. Nagsa-fluctuate yung internet. Sige. Okay, diagnosed siya with HF, REF. Okay, heart failure, reduced no ejection fraction, heart disease, ano nga ito, hypertensive heart disease. Okay. Ayan. And then, I agree na because of non-compliance, nag-worsen ang kanyang cardio no condition. Okay. And then, since ang main complaint ni patient ay stroke, okay, I think it's good then to include management of stroke, no, dito sa PCP ninyo. Or hindi ko lang ba napansin, or not sure. Meron ba group 4, management of stroke, cardioembolic?
Parang na-combine na namin po sa heart failure tsaka sa hypertensive heart disease. Bali, hindi na siya na lagay talaga na stroke lang.
Okay. Oo nga.
Pero
Kasi
sa
sabi na-
recommendation of therapy namin, nandun naman po siya.
Okay. So, ganun yun, ano, kahit, kumbaga, kung hindi siya na separate na entry, makikita pa rin, no, traceable pa rin siya, dapat kung ano yung dapat na monitoring or intervention sa stroke. Kasi nga, sabi natin, intertwined ang condition ni patient. Okay. Sige. So, management of heart failure. So, maintain normal heart rate. Okay. And medication adherence, ECG, electrolyte level, suggest to discontinue either warfarin or enoxaparin. Okay, sabi natin kanina, sa enoxaparin, okay siyang ibigay. 3 days lang naman siya, DVT prevention. And then si warfarin, anticoagulant, okay. Pero pag maintenance therapy, pwedeng aspirin or clopidogrel. Okay, let me just clarify this one, ha. Si warfarin, tsaka si aspirin plus clopidogrel, they can be both given as secondary prevention of stroke. Okay, ang catch lang natin dito, alin yung better for cardioembolic stroke? Kasi si patient is specific yung type of stroke na naandun sa kanya, cardioembolic. So ngayon, kailangan natin pumili which is the best or appropriate drug for a cardioembolic type of stroke. Ano ang i-maintenance ni patient? Warfarin ba? O yung combination na aspirin and clopidogrel? Okay. So, pwedeng, ano na yan, pwedeng yung i-check. Okay? Based sa pharmacotherapeutic guidelines natin. Okay. And then, after yung heart failure, management of hypertensive heart disease. Okay, maintain normal BP level. What type of hypertension? Anong category pala ng hypertension meron si patient? Kasi we have pre-hypertension, stage 1, stage 2. May I ask anyone? Ano yung
Stage 1 po.
stage 1?
Stage 1 yung na-maintain niya, pero stage 2, stage 2 pa pala. Stage 2 po pala.
Oh, stage 2. Okay. Bakit naging stage 2? Ma'am Shirley?
Consistent po kasi na yung diastolic niya na blood pressure is 90.
Okay.
And nagfo-fall po siya sa stage 2 pag 90 si diastolic kahit na si systolic is lower.
Okay. So management of hypertension stage 2. Okay. Same with other groups. Group 6, stage 2. Or chat na lang. Okay. Yes. Okay. So, ano ang goal natin dito? Okay. Thank you. Ano ang goal natin pag management of hypertension? Maintain normal BP level. Okay. So, very good ito. No? Nalilagay nyo dito yung monitoring parameter. So, it must be less than 130 or wait lang, less than or equal to 130 over 90. Sure? I-check ko din. Pero, sa ibang groups, correct tong 130, but the diastolic, is it 90 or 80? Based on JNCA tayo ha, yung BP goals natin, may
80 po.
80. Okay, sige. So, 130 over 80 or less than. So, that's the goal for the patient. Okay. Desired endpoint, less than 130 over 80. Okay. Ayan. Alright. Drug-induced hyperkalemia. O nga, no? Kasi sabi natin, there are so many drugs no contributing to to potassium yung ano no, yung potassium levels ni patient. Kaya strict ang monitoring ng kanyang serum potassium. Okay. Include, alright. Okay. Okay, sige. Alright. So ito ang top 3 na healthcare need ng group 4. And then we have three more groups. Kaya let's continue na discussing the other healthcare needs. Thank you so much, group 4. Andito na din, I think, si Ma'am Sheila.
Hi, sorry. Nali. Thank you.
Okay. Sige, group 3. Tama, Erica, no?
Yes, ma'am.
Yung time natin ay pa-paste na lang ulit sa chat. Thank you.
Sige po.
Siya mas-scroll up. Thank you.
Okay na po.
Okay, you may start, Ma'am Laika. Thank
Apo.
you.
So yung sa group 3 po, yung healthcare need po namin is, yung una po namin i-manage is yung acute CVD infarct, hyperglycemic po kasi si patient, so need po yun i-address muna. Kasi po yung hyperglycemia, ini-increase niya yung severity ng ischemic injury by causing lactic acidosis, increases production of free radicals, and worsens cerebral edema and weakens blood vessels. So yung pharmacotherapy goal po namin is to decrease sugar level to 4.1 to 5.9. Then recommendations and interventions of therapy may give human regular insulin for IU now, then continue CBG monitoring. And then suggest to have HbA1c since patient is high risk for DM based sa family history po. And then yung monitoring parameters, CBG monitoring, desired endpoint po is to normalize the blood sugar and so dapat po wala po siyang hypoglycemia, tachycardia, cold sweats, and etc. So frequency po ng monitoring is every 6 hours until normal values are achieved. And then yung second po namin is management of acute CVD. Yun pa din po pala. So yung sorry ma'am, paano? Wait lang po. So yung pharmacotherapeutic goal po is compliance to acute stroke management. And then yung recommendation pa namin is to give enoxaparin 6,000 IU, Q12, warfarin 2.5 mg OB, and suggest to test for APPT, INR, and monitoring parameters po, chest pain, INR, and prothrombin. Tapos yung desired endpoint po is to alleviate yung chest pain and signs of bleeding such as gum bleeding and melena. Tapos yung frequency po is daily and upon initiation of anticoagulant therapy. Tapos yung alleviation of chest pain can be by using enoxaparin po. So yung recommendation or intervention is to sorry po. Wait lang po.
Hi po. So ako na lang po magtutuloy no presentation. So, management of acute CVD infarct, compliance po sa acute stroke management and to alleviate chest pain yung ating pharmacotherapeutic goals. So, ang recommendation or interventions for therapy namin po is suggest to test for APTT, INR, and prothrombin time. And then, we suggest to discontinue na lang din po yung enoxaparin and continue na lang po yung warfarin. So, monitoring parameters, negative yung chest pain niya, wala ng chest pain, yung INR, PTT, and APTT. Desired endpoints po, wala ng chest pain and wala ding signs of bleeding such as gum bleeding and melena. So, frequency po is yung pag-check po ng signs of bleeding and melena is daily, and then yung sa INR, upon initiation of anticoagulation therapy. So, isa pa po sa mga in-address namin is yung management of heart failure. So, compliance to heart failure medications. And then, we suggest po na to increase yung dose po ng sacubitril plus valsartan to 200 mg BID as per target dose po ng guideline-directed medication therapy. Ang parameters po namin is normal heart rate and desired endpoint po natin, prevention of rehospitalization. And then, if nakita naman po na confirmed na si patient po natin is with DM, we may add empagliflozin 10 mg OD po. Parameters, monitoring parameters, normal blood sugar levels, and HbA1c. So, and the new frequency po is yung titration and optimization of PDMT every follow-up consultations. And then, isa pa po sa mga in-address namin is yung non-compliance ni patient dun sa medication niya. So, ang pharmacotherapeutic goal po namin is adherence to prescribed medications. And then, ang intervention po na gagawin is to conduct patient counseling at bedside with the family or caregiver, explain the need for adherence to medication since the patient is a known case of heart failure. We may also encourage the use of alarms to alert that medication is due in time. And the pharmacist may also provide a list of medications with its corresponding schedule. So, ang monitoring parameters po natin is yung mga counseling forms. Desired endpoint po natin is to prevent yung hospitalization ng patient, and the patient would be able to understand and adhere to his medications. So, frequency po, anytime at the ward habang naka-admit na siya, and before discharge po gagawin yung patient counseling. Lifestyle modification din po, prevent recurrent hospitalization and mag-improve yung kanyang right-sided weakness. Sa lifestyle modification, we will suggest na magkaroon siya ng restriction of dietary sodium intake para ma-reduce yung congestive symptoms. And kapag natotolerate naman na po ni patient mag-exercise, we may encourage regular physical activity. Desired endpoint po natin is yung lesser hospital admissions and improved quality of life. So, yung lifestyle modification po is gagawin siya daily. And then si patient din po kasi natin is gumagamit siya ng amphetamine last January 25, 2021 and alcohol drinker din po siya. So, ang pharmacotherapeutic goal po natin is ma-discontinue yung paggamit niya ng alcohol and methamphetamine. So, we may refer the patient to social work services or for psychiatry consultations. Ang desired endpoint po natin, patient will refrain from alcohol or illicit drug use. So, gagawin po natin ito before discharge po ng pasyente kasama po nung sa patient counseling. And then yung sa financial burden of costly medications, kasi yung mga bagong class po ng mga gamot for heart failure ngayon, like yung mga sacubitril, valsartan, ganun, medyo mahal po siya. So we may refer the patient to social work services for financial and medical assistance po. And we can also refer the patient to Philippine Heart Center for further monitoring and management. So ang desired endpoint po natin is to reduce the patient cost of medicine, thereby improving compliance to his medication. So gagawin po natin ito before discharge. Yun lang po.
Okay, thank you, Group 3. Sabi nga natin na walang mali sa pag-sequence as long as you can justify kung bakit yun yung una niyong prioritize na healthcare need. So yung number one, yung hyperglycemia, I appreciate this one kasi elevated blood glucose is really common in the early phase of stroke. It is pag mataas ang sugar, there is a greater risk of stroke occurrence. Kaya agree na i-address yung hyperglycemia kaagad. Okay, Ma'am Sheila, comments? Thank you.
Good morning. Sorry na late.
Morning.
Nakalimutan ko talaga ang workshop today. So, dito sa PCP, no, very good naman kasi madami kayong nakita na healthcare needs ni patient and siguro yung additional comments lang dito, okay din, no, na nakita niyo yung hyperglycemia doon. Yung sa monitoring parameters, i-specify lang natin yung level sa kung anong range siya dapat nandoon. And sa desired endpoint, ano yung specific na values na dapat makita, no? Kunyari, normal levels of blood sugar. So, anong level ba dapat, no? Kunyari, kung fasting blood sugar ba yun, anong level ang dapat? Kung HbA1c, ano yung level niya dapat, no? Kung less than anong percent pa siya. So, mas lang, specify natin. And okay din na nalagay nyo, no, yung mga signs of hypoglycemia. So, naka-enumerate siya. Dito din sa management of acute CVT, yung enoxaparin ba? Tama ba yung dose niya? Or sa other groups ba na-check niyo kung correct yung dose ng enoxaparin? Sa mga references niya ba, okay yung dose ng enoxaparin? Yes, Bas. Sige. May ano ba? May nag-adjust sa inyo ng dose ng enoxaparin from the previous group? Sorry, di ka na napanood. Sinadya. Ano siya? Hindi siya typo. So, dun sa case, no, I think kailangan i-adjust yung dose ng enoxaparin. Also, yung sa warfarin natin, meron ba sa inyong nag-replace ng warfarin to aspirin? From the other groups, meron ba? Yeah, so, I think mas better if i-suggest natin yung aspirin as replacement for warfarin para check din, no? Baka nagkamali din ang check ko. So, yun. And then, dito sa mga side effects, so pwede natin i-enumerate pa yung effects nung mga drugs niya, like yung enoxaparin, ano yung mga, ayan, signs of bleeding, Tama, pwede. So, gum bleeding, ano pa, melena. Okay. And also yung other drugs niya, pwede pang i-enumerate din yung kanilang side effects. Tama naman, negative yung chest pain. Yung INR, if nakalagay dito, so ano yung kanyang desired endpoint, no? Ano yung values na titingnan sa INR para mag-guide rin yung kasama natin na pharmacist na mag-check. Dapat ba within 2 to 3 siya or ganyan. No? So, and kailan yung monitoring ng INR. So, lahat nung ilalagay natin sa parameters, may ano siya, katumbas na kung anong monitoring na endpoint and ano yung frequency. So, itama niyo i-level niya siya dun sa table, no? Tapos kung ano yung next, so yung katapat niya doon sa frequency para mas clear doon sa titingin ng PCP ninyo, no? Kung may kasama kayong clinical pharmacist na mag-check din doon sa patient. Also sa management ng heart failure, ayan. So tama naman, yung normal heart rate, so yan, ilagay ulit ano yung normal heart rate ba and normal blood sugar levels, also HbA1c. So okay naman na-address niyo yung non-compliance, tas adherence to prescribed medications as well as lifestyle modification, tsaka yung substance use niya. So, dito yung counseling din talaga kasi pagkatapos niyang admit sa hospital, pwedeng mag-continue siya nung kanyang mga vices like alcohol and methamphetamine. So, maganda na kasama siya sa plan din ninyo na before discharge, ma-counsel mo na yung patient or ma-refer siya to services. Okay. And also yung financial burden ng kanyang medications. So, thank you, group. Ano nga bang group ito? Group
3.
Group 3.
Group 3.
Tama. Thank you.
Okay. Okay, so next would be group 2 to present also the PCP.
So good morning, everyone. I'm Zalajan Bibosa. So I'll be presenting for Group 2. So our pharmacist care plan are as follows. So first, Ma'am Ariane.
Nakikita po, ma'am.
Nakikita na po. Thank you.
Okay po. Thank you, ma'am. Sorry po.
So our first healthcare need is management of hyperglycemia. So our pharmacotherapeutic goal is to maintain HbA1c at 6%. Then recommendations or interventions for therapy. So I will not go into details na lang po kasi almost the same lang naman for other groups. So ang sa amin lang is we would recommend empagliflozin 10 milligrams OD, which is found to be beneficial to patients with HF kasi according to our references po, for patients with heart failure, empagliflozin has shown most prominent na desired effect, prominent na hypoglycemic effect sa mga patients. Then monitoring parameters would be HbA1c, CBG monitoring, and side effects such as hypoglycemia. So our desired endpoint is that HbA1c should be 6% na lang yung level niya, and for CBG is 70 to 100 milligrams per deciliter. So the monitoring for HbA1c should be done every 3 months and daily monitoring for CBG. Then we also include recommendations for lifestyle modifications na here. Tapos it is to avoid intake that is high in sugar, and may consult nutritionist to help with hyperglycemic diet, and also exercise, and to limit alcohol consumption and smoking cessation. And also we included here the patient education, which is to advise the patient on how different therapies work, and how he can benefit to these medications and in taking them, and the need for the compliance. And also we would suggest we would dig deeper into how, why he is non-adherent to his medication. So is it financially, is it a financial problem, or is just that he forgets to take them? So from there on, we could address how we can manage adherence sa patient. The next healthcare need is management of hypertension, and that to maintain BP at less than 130 per 80 po, over 80, then compliance with antihypertensive medication. So our recommendation is that for hypertension is carvedilol 6.25 milligrams tablet BID, and also not to discontinue abruptly, as this can exacerbate his angina and may lead to myocardial infarction. And for monitoring parameters is to monitor BP, HR, heart rate, creatinine, serum potassium, and side effects such as hypotension, fatigue, and nausea. So our BP goal is 130, not more than 130 to 8/80 na blood pressure, and heart rate of 60 to 100. Then daily BP measurement, as well as recording din para makita ng physician niya in case of a follow-up yung average blood pressure niya. The next is also we have included lifestyle modifications. So for hypertensive patient, less salt, limit the salt intake to 2 to 3 grams a day, exercise, lessen alcohol consumption, or as much as possible, no alcohol consumption, and then smoking cessation. So next healthcare need is management of coronary artery disease. So since the patient have experienced stroke tsaka ng infarct, so first chief complaint niya kasi is elevation of chest pain and dyspnea. So according sa patient case kasi, wala kasing naibigay, hindi kasi nalagay doon kung nabigyan ba siya to alleviate the pain since it's a myocardial infarct or a stroke. We think lang po na administration of isosorbide dinitrate 5 milligrams tablet sublingually as needed for chest pain should be given to the patient every 5 to 10 minutes and must not exceed max of 3 doses po. Then as a part of monitoring parameter is chest x-ray, then arterial blood gas, then there's monitoring also for side effects, which is hypotension and headache for ISDN. Then desired outcome is a normal chest x-ray results, arterial for dyspnea po ito, for dyspnea po niya to address. Arterial blood gas, which are the following. So pH dapat should be 7.35 to 7.45, partial carbon dioxide 35 to 45 mmHg, then partial O2 90 to 100 milligrams mmHg, then bicarbonate is 20 to 26 mmol per liter. So re-evaluation every month if angina is stabilized. The next is prevention of complications from coronary artery disease. Since si patient nagkaroon na siya ng stroke, so it would be possible na there would be recurrence of stroke. So to prevent further attacks of stroke or infarct, our pharmacotherapeutic goal should be compliance ni patient talaga sa kanyang ACS regimen. So our ACS regimen is aspirin 80 milligram OD tablet, then clopidogrel 75 milligrams tablet OD, and atorvastatin na-retain namin si 80 milligrams ODHS tablet. So si warfarin kinuha na diniscontinue na namin siya as din kasi sa behavior ni patient is that may tendency siya of non-compliance. So masyadong mahirap if ibigay din si warfarin kasi si warfarin has narrow therapeutic index. So if bigla lang mag-discontinue or may mga missed doses, mas maka-exacerbate siya ng condition ni patient. Then the lab markers or monitoring parameters for this are BUN, TROP-I, AST, ALT, EKG or ECG, then monitor for arrhythmia. So BUN should be 5 to 20 milligrams per deciliter, then TROP-I 0 to 0.04 ng per ml, then AST, ALT 30 to 65 IU per liter. For AST, then for ALT 15 to 37 units per liter, then regular sinus rhythm sana siya for since prevent natin yung arrhythmia. So it should be ang ECG niya is regular sinus rhythm. So we also have to monitor side effects for aspirin such as GI irritation. If ever na may GI irritation si patient, aspirin EC could be given. Then for atorvastatin is rhabdomyolysis, muscle weakness, and fatigue. Then next, under sa management ng coronary artery disease niya is nilagay namin si management of heart failure. Kasi patient was already diagnosed with heart failure, so kailangan lang natin siyang i-manage. Then ang compliance, make sure lang na compliant and adherent si patient sa kanyang heart failure regimen, which are the sacubitril, valsartan 50 milligrams BID, carvedilol 6.25 milligrams tablet BID, and na-retain namin si spironolactone 25 milligrams tablet OD because according sa references, spironolactone in combination with the beta blockers kasi daw, they shown mas beneficial po sila para sa mga patient na may heart failure. However, if later I will discuss po. So, target desired lab parameters are the following. So, yung ejection fraction ni patient, BNP, and also to monitor patient for muscle weakness and angioedema since the patient is taking an ARBs. So monitor for any swelling on any parts of the body. Then for spironolactone is hyperkalemia, arrhythmia, hypotension, hyponatremia, and hypomagnesemia. So desired goal should be the ejection fraction should not be less than 40% and BNP 18.57. So sa frequency, this should be done frequently, like monthly, during follow-up niya sa doctor. Then monitor serum potassium within 1 week of initiation or titration of spironolactone and regularly thereafter. If hyperkalemia occurs, saka na itatry na i-reduce yung dose or discontinue treatment if it would cause detrimental effects to the patient. The next is management of vitamin B deficiency. So it is evident sa kanyang, so ang ating pharmacotherapeutic goal is to normalize patient lab values, then may consider adding vitamin B supplements to patient medication. So our laboratory markers are ALT, SGPT, then RBC lab values. So then the desired outcome is that all these lab values are within normal range and monitoring at least 3 months. I think that would be all.
Thank you. Thank you, Group 2. Konting comment lang dito kasi sa inyo lumabas itong, pero kanina I think na-discuss na rin yung vitamin B deficiency, no, na-mention natin. Ma'am, pa-scroll down ako ng onte. Na pababa lang, ayan. Okay. So yung reason, ma'am, what I mean is, mababa yung ALT, kaya parang kinonect sa vitamin B deficiency. Tama ba, Ma'am Zala?
Yes po, Ma'am Jean.
Okay. So, pag pag nagkaroon ng supplementation ng vitamin B, then pwedeng mag-normalize na yung ALT. No? Tapos, yung monitoring ninyo would be, of course, na yung levels ng ALT or SGPT. Okay. I will add lang, kasi yung ALT is related to, could indicate, kasi ang vitamin B6 deficiency could also indicate a kidney problem. Na ang kidney problem is actually a common complication among patients hospitalized due to stroke. So, pwede sanang makatulong kung meron ding lab values, no, yung proteinuria, albuminuria. So we can say na may kidney disease. But for now, since kailangan pa ng more information, okay, I think correct pa rin ito na nilink ninyo siya sa vitamin B deficiency because we cannot yet confirm na meron siyang kidney injury as complication after stroke. Sheet.
Okay, Jean. Thank you. Okay din na nakita ninyo na yung sa spironolactone na effect ng hyperkalemia and i-monitor ninyo. Okay lang ba, ma'am, itaas? Ayan, okay. So kung mapansin nyo, no, kanina yung sa previous na group, yung management ng hyperglycemia ay under siya ng CVD na management, no? So ito, hiniwalay nila yung healthcare needs. So pwede naman, no, na hiwalay siya kasi yung patient naman talaga ay at risk siya for DM since yung family history niya na merong DM yung siblings. So, pwede naman na nakahiwalay talaga yung healthcare need niya for management of hyperglycemia kasi pwede rin na dahil sa other conditions niya kaya tumaas yung sugar. So, yan. And then yung goal niya dito is maintain HbA1c or pwedeng normalize yung kanyang blood sugar level. Tas isa lang sa monitoring parameters yung HbA1c and then yung fasting blood sugar niya, for example. So, pwedeng i-add dito. And tama naman na meron siyang desired endpoint. So, pwede rin, ma'am, ilagay dito sa monitoring parameters. Although yung desired endpoint niyo ay, ano ba to, less than 6%. No? So, yung dito sa monitoring parameters, yung range na dapat nandoon siya. Tapos yung desired endpoint, andyan yung pinaka-goal niya for that patient. No? And kung mapansin nyo yung kanyang lifestyle modification sa previous group, another healthcare need siya. So dito, nilagay nila sa recommendations na for therapy. No? So pwede naman kung talagang yung lifestyle na modification na yan ay specific for that condition. So okay din na nakalagay na siya dyan sa recommendations or interventions for therapy. Tapos, naka-enumerate na siya na ano yung dapat na gawin. So, correct naman siya. No? Sa next na page, ma'am. Ayan. So, management ng hypertension. So, nandun din yung lifestyle modifications nakasulat na para mas kita kung ano yung modification na dapat per condition ni patient. So, para mas madali rin mag-explain kay patient, no, na ito yung kailangan mo para manage yung hypertension. Ganyan. Okay naman yung kanyang parameters sa coronary artery disease. Itong ISDN, no? May nag-recommend ba na other groups or itong group lang yung meron? May other groups ba? Can you raise your hand if bigay din kayo ng ISDN sa patient? Walang other groups na nagbigay? Okay, so itong group lang, no? So, pag ganito na mag-recommend tayo, ma'am, check nyo rin if may other drug interactions siya, na dun sa mga re-recommend pa lang ng meds ng patient na idadagdag dun sa kanyang current na therapy. So, check nyo din if may interactions siya sa mga current na medications niya. So, kung ito ay provided no nung reference na ginamit ninyo, so i-note nyo na lang din dun sa patient sa pharmacist notes ano yung reference na ginamit ninyo, and if talagang needed siya ni patient no doon sa management ng coronary artery disease niya. Dun sa atorvastatin, meron bang na group na nagpalit ng dose ni atorvastatin? Okay, so may group no ni Ma'am Grace Alcantara. Okay, so dun sa remaining groups, check niya rin no if need na i-lower yung dose niya. Okay, thank you Ma'am Grace. So check niya rin if need na i-lower yung dose or same na dose pa din siya. Okay, and then dun sa management ng heart failure. Okay. Sige, so far, no, parang ito pa lang din naman yung napansin ko. Also yung ano pala, yung nakalimutan ko, lactulose. Meron ba sa inyong nag-adjust ng dose niya? Also yung digoxin. Okay. So check niya rin na yung mga dose kung appropriate ba siya sa patient. Kung nakita niyo na need i-lower, so yun, kailangan niyo i-discuss sa pharmacist notes bakit kailangan i-lower yung dose no, ng mga meds ni patient. Okay, thank you so much. Sige, so thank you group 2. Tama ba? Nawala ako group 2. Okay.
Yes, group
Thank
2.
you. Sige.
Okay, thank you, Ma'am Shi. So we're down to the last group, group 1. Okay. Group 1, you may now start sharing your screen. Thank you.
Ayan, good morning po. I'm Glenna Gatchalian and we'll be discussing our pharmacy's care plan for the patient. And nakikita po yung share screen ko po.
Yes,
PCP.
ma'am.
Ayan, so pharmacy's care plan. Nag-base po kami dun sa mga problems na na-encounter po namin with the case of the patient. So first po namin na priority would be management of cardiomegaly, especially may positive po yung impression sa patient. So ang pharmacotherapeutic goal namin would be to decrease signs and symptoms of cardiomegaly, including chest pain, discomfort in other areas, severe shortness of breath, and then fainting. So ang recommendation po namin would be prescribing medications that would help alleviate or control signs and symptoms of cardiomegaly. Same pa rin po siya dun sa mga past medical, mga past meds po niya, enalapril, carvedilol, digoxin, spironolactone, and aspirin. And then sa monitoring parameters po namin, BP would be 130/90, heart rate dapat po within the normal range, respiratory rate po natin kasi increased yung respiratory rate ng patient, so ang goal po natin is to make it to the normal level that would be 12 to 16 breath per minute, and then yung kanyang oxygen concentration is supposed to be 75 to 100 mmHg. Yun, so desired endpoint po namin is minimal to no signs and symptoms of manifestation po nung kanya mga discomfort. Frequency would be Q8 every 8 hours kasi sa hospital naman po, mamomonitor din naman po natin siya. And then, drugs without medical indication, yun. So, yung clindamycin and ceftriaxone po kanina, it's ang goal po kasi niya is to eliminate bacterial infection. But we recommend to discontinue antibiotics, especially wala pa po silang culture sensitivity test na nakalabas and with no microorganisms found po. And every 3 days po, chine-check yung kanilang culture sensitivity if may microorganism growth. With regards to atorvastatin, ang goal po kasi ng atorvastatin is to control elevation of cholesterol and triglycerides. But we recommend to discontinue it since dun po sa parameters sa laboratory po ng patient, nasa normal level naman po yung cholesterol and triglycerides po ng patient. And next po, healthcare need po ng patient would be the regulation of bowel movement of patient. Ang goal po natin would be regular bowel movement of patient not induced by medicine. So we recommend lactulose frequency may be reduced to ODHS, 30 ml ODHS. And yung kanyang monitoring parameters would be monitoring of frequency of bowel input. Doon po kasi sa case presentation po natin, wala pa pong, hindi po na-indicate doon yung input output po ng patient. So we recommend to monitor it. And ang goal po natin is bowel movement 3 times a day. Tapos monitoring natin is 3 times a day din po. And then, we also need to avoid drug and drug interactions in patients' medications. Yung hinighlight po namin dito is dioxin and carvedilol, which would increase digoxin concentrations. Ang goal po natin doon is to avoid possible digoxin toxicity, and ang parameters po natin is the digoxin plasma concentration level. The level should be 0.5 to 0.9 ng per ml. Tapos every 3 days po yung laboratory check po natin. And then, we would also like to avoid therapeutic duplication if not necessary, especially po with the warfarin and enoxaparin niya. Ang both kasi warfarin and enoxaparin is used to treat acute deep vein thrombosis with or without pulmonary embolism. Pero with the patient kasi, kung prescribe po siya ng doctor, we would recommend to monitor the INR of the patient. And the INR range should be 2.0 to 3.0, and it should be monitored every 3 days. Yan. And with patient counseling, alam po natin yung patient is very known for non-compliance of his medicines. So it would be great if notice natin na healthcare need po niya ang patient counseling, especially to adherence to medical regimens. Yan. So ang goal natin is to take medicines properly without misdose. So ipi-patient counsel natin siya. And ang parameter natin would be medicine administered proper time with right dose and complete medicines given. So every day po, i-monitor natin yung patient kung nabibigay nga po yung gamot sa kanya. And with regards to the alcohol withdrawal and sa social drugs withdrawal niya, we would recommend to let him enroll sa mga Alcohol Anonymous or sa rehab with regards to it. So we also have to do patient counsel and monitor the patient monthly. So yun po.
Okay, thank you so much, ma'am. So let's give a round of applause to last group na, Jean. Tama ba?
Yes.
Okay,
Yes,
last group. Sige. So, ay, okay lang ba ma'am pa-share ulit muna ng screen?
Ma'am Shi, I think they can also report the pharmacist notes.
Sige.
Yung group 1.
Okay, okay.
Okay po. Sige po, i-share ko po yung pharmacist notes namin and I would call Ma'am Cyril to elaborate on it po.
Okay, thank you, Ma'am Glenda. And then after that, ayan na, brief na tayo, open forum. So, Ma'am Cyril, thank you.
Hello po. Wait lang po natin yung screen share ni Ma'am Glenn. Okay. This is pharmacist notes. Before I start, may I please introduce what we do in our hospital. So I have a sample here. Ma'am Glenn, yun daw pong isang sample. Wait. Ayan. This is a sample based on the UP example of the pharmacist notes na ginagawa ko na po sa aming hospital. So as you can see, my pharmacist notes based addressed to the doctor, and here recommendation is respectfully informing that omeprazole and clopidogrel are used concomitantly. Omeprazole decrease antiplatelet activity of the clopidogrel. So ang discussion pong nilagay ko, drug-drug interaction. So mostly as you can ma'am, this is dated 2020 pa because nag-evolve ito mga pharmacist notes namin. Dati po kasi ini-stapler ko lang to sa doctor's order. Since yung mga IM po namin na sila na bakit may naka-stapler? So, they recommend na isulat ko na daw po dun sa isang part ng doctor's note yung aking pharmacist notes, which is very good naman po kasi every time nako-call yung attention nila. Every time na malagay po ako nito. And meron pa rin po akong isang example na maliban po dito sa drug-drug interaction. Ma'am Glenn, next slide po. Ayan. Like this din po, respectfully notifying that antibiotics of Triaxan 2 grams OD has been used for 9 days. So ang discussion pong nilagay ko, automatic 7-day stop order. And automatically po, pag meron po nitong nakalagay na notice, ini-stop na po ng doctor or naku-call yung attention ng doctor, which is good po for the patient's care naman. And kuminsan din po, not even the doctors, the nurses, call the attention of the doctor kahit hindi ko pa po yan naku-call yung attention, sila na din po. So, collaboration para sa patient goal talaga po na ma-improve yung patient care niya. So, let's go back na po dun sa pharmacist notes. Sharing ko lang po ito sa aming hospital. Okay. Okay. So, ito po ay mga recommendations ng Group 1. So, number 1, recommend to discontinue antibiotic unless culture and sensitivity test has been done and there is a clear indication for the need of antibiotic. Kasi nasabi po namin dun sa PCP namin na there is no need for antibiotic unless merong pinakikita dun sa culture and sensitivity test. So most probably, ma'am, the number 1 lalagay po dyan sa recommendation namin and sa discussion, yun yung results ng culture and sensitivity test, ma'am, ang i-represent namin sa doctor. So number 2, recommend po to discontinue atorvastatin based on having a normal level of cholesterol and triglycerides in the latest laboratory and to continue monitoring parameters to stabilize average value for the patient. Number 3, we recommend too na lactulose frequency may be reduced to ODHS from BID and monitor frequency of output of patients. Number 4, continue monitoring digoxin plasma concentration level with concurrent use of carvedilol. So number 5, monitor INR of the patient during the enoxaparin and warfarin regimen. And number 6 and last, patient counseling regarding adherence to medicines, alcohol withdrawal, and effects of social drugs in patient's current situation. So we have a total of 6 recommendations na possible for actions na mangyari sa patient care, ma'am. That's all.
Okay, thank you, Ma'am Cyril. Ayan.
Thank you, ma'am.
Dito sa mga recommendations na to, so bawat isa dyan, isang pharmacist notes yung gagawin, no? Yung
Yes,
isang
ma'am.
paper. So parang hiwa-hiwalay po
Yes,
ito.
ma'am.
Pero nakalagay lang dito, naka-enumerate kila Ma'am Cyril para may discussion, no? Bakit kailangan ng ganitong recommendation and ano yung reference niyo for this para mas clear dun sa physician ano yung gagawin niya. And pag naglagay po ng recommendation, no? So correct yung kaninang pinakita nila Ma'am Cyril, no? May ano siya, respectfully recommending chuchu, no? Para hindi naman parang ma-offend yung physician na bakit
Yes,
pinapapalitan
ma'am.
nito, no? So andun pa rin na parang decision pa rin ng physician, pero ito yung evidence na pinipresent ninyo. Ayan. So, thank you, Ma'am Cyril. So, clear lang dapat, no, kung ano yung gagawin ni physician pag binasa niya. Ano bang gagawin ko? Magpapa-order ba ako ng lab test or ganito, ganyan? So, yan. Okay. So, pwede po ba, Ma'am, i-present yung sa PCP natin? So bago ko lang makalimutan dahil na-mention kanina, may clopidogrel, may isang group kanina na clopidogrel aspirin. So check lang, no, if pwede silang concomitant use, baka hindi siya okay. So tingnan na lang nung group na yon na if pwede ang use ng aspirin clopidogrel at the same time. And if hindi pwede, so pili lang ng isa. Yung sa healthcare need, no, so dito enumerate naman, no, ano yung pharmacotherapeutic goal, tapos ano yung mga symptoms, no? So pwedeng etong symptoms man pwede na rin dito sa monitoring parameter. So pwede niyo siya ilipat diyan. Tapos yung pharmacotherapeutic niya, goal niya talaga ay to decrease signs and symptoms, ganyan. Okay. Tapos yung desired endpoint, ano yung endpoint niya doon? So pwede niyong ulitin yung values na nakalagay dito sa monitoring parameters if same siya. Dun sa without a medical indication, no? So okay naman na nakita niya yung clindamycin, ceftriaxone. So sa other groups din, no, tingnan niyo lahat ng gamot ba ay na-address na dito sa PCP. So meron nga siyang antibiotics, and although tama naman na discontinue yung antibiotics, pero I think na-discontinue na siya, ma'am, no, dun sa case ni patient. Kailan nga ba siya na-discontinue? Somewhere, basta na-discontinue siya. So kahit hindi na i-recommend yung discontinuation ng antibiotics, pero pwedeng i-note siya na address na yung problem na yon na dun sa drug therapy assessment worksheet or dun sa problem list ninyo, pwedeng nakalagay na discontinued already para alam na nakita niyo yung problem, tapos ito yung ginawa na, no? Dun sa mga nakakita nung sa antibiotics, bakit kaya siya binigay? Ano yung sinususpect na bacterial infection? Although hindi kasi siya nakalagay sa chief complaint. Okay. So, yung may infiltration siya sa lungs. Pwede rin kasing tingnan, no, na baka dahil sa heart failure niya kaya meron na nakita sa x-ray doon sa may lungs niya, baka merong tawag nito, nagkaroon ng fluid doon sa lungs or nagkaroon ng edema. Pero dahil more on infection yung siguro nakita nung sa x-ray, kaya binigyan siya ng antibiotics, and then diniscontinue na lang kasi walang growth dun sa sputum. Pero pwede rin tingnan natin, no, kasi yung yung respiratory rate niya ay mataas. So pwedeng dahil sa heart failure niya kaya mataas yung respiratory rate niya, or pwede rin na yung patient kasi is at risk din for COPD dahil 15 years siyang sisigarilyo na, no? So pwede rin siyang maging part ng healthcare need ni patient kasi syempre paglabas niya ng hospital, ulit yun, balik ulit siya sa dati niyang gawin, no? So pwedeng smoking cessation, and i-check, no, if patient nga ay meron siyang lung na problem. Okay, tapos dito sa statin, so correct naman ma'am na chinek ninyo yung blood lab, yung chinek nyo yung lab result niya, no? Yung kanyang cholesterol nga ay mababa na. Tama ba? Sana ba yun? Hanap ko. Cholesterol. Ayan, mababa na yung cholesterol niya, no? Anong date ito? So, pwede na nga siyang i-stop, pero siguro need pa ng additional na, kasi pwedeng drug-induced, tapos the next day ay tumaas ulit yung cholesterol level niya, no? So, pwede sigurong another lab result for cholesterol, lipid profile niya, and then if pwede na talagang i-stop, no? Kasi nasa normal na yung kanyang triglycerides and and mga enzymes niya dyan. So, yun. So, pwede na i-recommend to stop. Yung sa regulation naman ng bowel movement ni patient, hindi naman siguro need na regular bowel movement yung kanyang ano dyan, yung goal. Kasi 'di ba yung kanyang sakit ay yung sa heart niya. So para binibigay ang lactulose to reduce yung strain ni patient kapag nagpupupo, no? So usually binibigay talaga siya sa mga patients na kailangan i-reduce yung strain sa heart kapag nagkakaroon ng bowel movement. So siguro yung normal na, although pareha din sa mga previous na groups, no, yung pwedeng maging pharmacotherapeutic goal dito is to reduce strain during evacuation of bowel, etc. No? Pero yun, hindi naman need na regular bowel movement. And okay lang, no, yung mga next na yan na column. Tapos, ayan, digoxin carvedilol. Okay, so pwede na yung monitoring ng drug-drug interactions, and if meron pang other drugs na may interactions, so part din ng monitoring, no, dito sa PCP, dapat ipakita siya dito sa PCP. Okay, so I think okay naman na yung mga next, ma'am, no? So ganun na lang, no, sa lahat ng groups. Kung nakita ninyo na ito yung pinaka-immediate need ni patient, so pwedeng ito yung nauna. And depende, no, sa team talaga kung ano yung nakikita niyong unang problem na i-address. And if pwede siyang i-lump together doon sa under ng one healthcare need, yung pharmacotherapeutic goal, may mga bullet lang ng pharmacotherapeutic goal, pero under siya ng management, for example, ng heart failure lang niya. Hindi ko napansin lang din na yung, tama ba kasi na stroke na siya? Siguro dun sa isa sa mga therapeutic goal din ay yung prevent yung recurrence ng stroke. Although nandoon naman na yung compliance with the medication, pero yun, isa sa mga goal din natin kapag nagkakaroon sila ng stroke ay i-prevent yung recurrence. Feeling ko okay naman na yung lahat, no, na-address naman na. So yung mga additional na comments doon na lang sa Canvas. Hindi ko pa na-check dahil nagkaroon ulit ng work ng Thursday, Friday. So ayun, i-note ko na lang din sa Canvas kami ni Ma'am Jean kung may mga additional na comments pa sa mga groups na. Pero so far, very good naman po ang mga nag-present. So congratulations sa inyong lahat. No? Give yourselves a round of applause. So ready naman na, no? na maggawa kayo ng inyong clinical pharmacist na role sa hospitals ninyo. So thank you so much. Yes, Ma'am Jean.
Thank you so much to everyone. If you have plans na to adapt the forms or mag-start kayo ng initiative ng clinical program ninyo sa inyong mga institution, so you can use the documents. Basta kung yung PGH forms, you can just acknowledge na as na naging reference ninyo, or pwede naman na dagdagan or i-improve nyo kung ano man yung gusto nyo maging format ng forms ng clinical forms ninyo no para akma sa needs ng inyong institution. Okay. So naway may natutunan po sa workshop na ito at may na ibigay din kami ni Ma'am Sheila. Thank you everyone.
Thank you so much. Picture tayo. Picture tayo as a group. Ayan. On na lang po ng camera para makapag-picture si Erica. Ayan. Happy Sunday sa inyong lahat. Pasensya na, nakalimutan ko talaga. Nagulat ako sa text ni
Happy Sunday, ma'am.
Happy Sunday. Feeling ko kasi ay weekend. So talaga in-enjoy ko aking weekend. Nakalimutan ko may workshop pala. Salamat ng marami sa inyo. Ayan, ready na po. Sila Ma'am Shannon, Ma'am Jillian, Ma'am Jeanette, Ma'am Laika. Okay lang kahit hindi pa naka-makeup.
Ayan, sige.
Okay.
So, smile po tayo. 1, 2, 3. Okay, thank you.
Thank you po.
Thank you. Pwede na
Ma'am Sheila,
mag-rest.
Ma'am Jean.
Thank you po, Ma'am
You're
Jean, Ma'am
welcome,
Sheila.
ma'am.
Thank you po, Ma'am Erica.
Thank you po.
Okay.
Thank you po sa
Enjoy
lahat.
the rest of the
Thank you
day.
po.
You're welcome. Ingat
Thank you,
kayo.
Group 1.
Bye-bye.
Ingat kayo. Bye.